Okay, let's get started. Any questions today? Must be Friday. Nobody here. Okay.
We have a law. We have a
Oh, law, yes. No. It's not changed since I had it, really, actually. But all right. I think we're ready to start talking about social phobias or phobic disorders, if I'm correct. These come on early, so if you have fears about things, those came on early in life usually. So a couple different things, but social is probably the biggest issue, and then some specific phobias. So social anxiety disorder or social phobia can be called either of those. It's any process in which people feel humiliated in anticipation of something they might do, public speaking or other types of things where other people theoretically are looking at them or watching them and evaluating them, but other things as well in front of groups, including dating and other public situations. So panic can occur from those that they get very stressed by that in that situation, and they can get panic attacks actually. Does anyone remember there was a television show called Fear Factor, I think it was, right? It was a game show. So they were taking advantage of whatever those fears were in most people. Some people weren't fearful of some of those things. Some of those individuals probably ended up suing them, which is probably why it went off the air, even though they would have signed off some waiver about that. But it induced some more permanency. So they had to do these events that instilled this fear. And there were a few times that people said, when I remember seeing it, that they would have nightmares after that for the rest of their life. So that was meaning that they potentially were going to induce something, and what they induced was post-traumatic stress disorder probably. So in some of those events, it went on to something else when they're pushed into that kind of situation, in an acute situation. I remember one, and specifically they had to put these increasingly sized needle bore sizes into their arm and thread them through, and they had to put 9 in their arm, I think. And a couple people on that one said that they would have nightmares for the rest of their lives about that. So they probably got sued. I don't think it went off the air because it wasn't popular, but. So they can have big impacts, these fear issues, and then what happens to them. Treatments, again, if it's something that's happening on a day-to-day basis, so it's something that they have to, that's true for specific phobias as well. If it's something that's involving their job that they're fearful about, whatever, then you're talking about treating it longer chronically kind of to help cover that. So then looking at the antidepressants, SSRIs in particular, or monoamine oxidase inhibitors or other antidepressants to help control that all the time would be kind of the primary place to go. Benzodiazepines and beta blockers can be used for those kind of as-needed situations. If they weren't going to do it or be in front of a crowd all the time, then at times when they do that, that would be significant. So lots of times people that are public speakers, sometimes some very good public speakers actually use beta blockers. I'm always surprised when I go to national conferences and have helped out on committees to help for speakers and doing those kind of things in front of fairly large crowds, that the speaker will be taking a beta blocker just half hour before, 20 minutes before. Some people that I thought were excellent speakers, and I wouldn't have been able to tell there was any kind of concern or fear there. But so that happens pretty frequently. When you use those medications like that, you have to be very cautious, however, because the side effects are pretty profound. So, the benzodiazepine is going to cause that sedative process. So if they're just taking it before they need to do something, that might inhibit that or cause trouble with that, making them too sleepy or not able to remember things and make it hard to do whatever task it is they're trying to do. And beta blockers can certainly lower heart rate and drop blood pressure, so then people sometimes don't feel well during the process when they're on that. So they kind of have to try those out and figure out how that impacts them, in particular beta blockers. So they usually start at small doses, propranolol or atenolol. We use a couple different products, and then kind of titrate or play around with the dosing a little bit. How does it make them feel? And you have to time it right, so taking it enough time beforehand so it's kind of onsetting and working. But you have to be careful. When I was a resident, one of my colleagues, we were 5 of us in my class or group, we had to present these formal presentations. We had, I think, 5 of them or 6 of them to do during the course of the year. They were very exacting. They had to be 40 minutes long, and there was a question period of time. And it was way before the day of PowerPoints. We had to make slides. You had to pay to have them made and have a slide carousel, and it always broke, and something happened every time. So it was expensive. It actually cost usually about $80 actually that we had to pay out of pocket for each presentation. And then the frustration and the challenge was that you're giving it to an audience, including faculty and preceptors and physicians and pharmacists and students and a number of people, usually about probably 35 or 40 people. And then at the end, what would happen, the audience could ask questions, and then everybody went out after that, though, except for the preceptors or faculty. And then they verbally critiqued you. And it wasn't positive, usually. It was all the negative things. So it was kind of frustrating. It was challenging. The idea was that you would get better, as the process went. It didn't really matter what your topic was. It was about the presentation and capabilities to do that and practice doing that. And so that's kind of what the process was. So one of my colleagues would talk too fast. So you'd really get docked for that. You'd get negative points, so to speak, for talking too fast and getting done earlier than you're supposed to. So instead of 40 minutes, he'd be done at 30 or 35 or whatever. So he would get some negative comments about that. So none of the rest of us really knew this. The very last presentation should have been the best, right? So we've worked up, we've practiced, we've done this and done this and done this and gotten feedback. So the very last presentation, he's standing at the podium, and the rest of us, the class, we would sit right in the front row, theoretically for moral support, but we really just heckled them, each other mostly. But so we're sitting right in the front. He's right there. He's holding on to the podium. It was a big podium. He was holding on to it the entire time, and he would not let go of it. And he wasn't even moving his hand or using the pointer or anything at the slides. He wasn't doing anything. And he was talking faster than he ever had. And he got done like 10 minutes early. So at the end, the whole question thing, and then they went out, and the staff and the faculty right at the end, somebody just right away said, what was going on? This is the worst presentation you've ever given, actually. So he confesses then that he had been taking Atenolol from the beginning. His wife was actually a family practice resident. So he'd been getting Atenolol from her. He was taking that. He took small doses the first few presentations. He didn't think it helped a whole lot. So the very last presentation, he took 200 milligrams. And he said he was so lightheaded and thought he was going to pass out that he was just going as fast as he could so he wouldn't fall down up in front of the crowd. So the moral of the story is you have to be careful. You have to know what those doses make you feel like, and you can't just blindly take them and go jump on the stage or do whatever and start performing, because it's going to have some impact. So he made a big mistake on that. He should have tried it out and made sure that that kind of dosage was something he could tolerate, and it wasn't. The other area here for social anxiety disorders, most of the time people, it isn't a job-dependent kind of issue. So there are other ways of doing it through cognitive behavioral therapy or working with therapists or exposure therapy, types of things to help people learn skills to cope with how they feel in that kind of situation. So if someone is fearful of small spaces and they can't get on the elevator to ride up in a building, whatever, and they really want to overcome that, then from a therapy perspective, what you do is you put them in small spaces, the therapist does. Gets them to talk about what they feel like and work through ways to make them feel more comfortable in that kind of situation, and eventually they're able to do it. So if it's an elevator issue, eventually you get them in the elevator, it doesn't move, the door stays open, they get them comfortable with that, then the door closes, it doesn't move, you get them comfortable with that, and then eventually the elevator's moving and you get them comfortable with that. So it's a long process actually to try to do that exposure therapy or social skills training. But that is one way to get past social anxiety disorder as well as specific phobias. So specific phobias are specific types of things, and they come in these categories. So animals, blood injection type, natural environmental, situational, and then other. Most of the treatment here, again, is avoidance. If you're scared of spiders, you stay away from them. If you're scared of heights, you don't work as a window washer on skyscrapers, whatever. You kind of stay away from the fear, whatever the object is. But some people have to experience some component of that in their job or day-to-day activities, and then we need to overcome that if they have those specific types of phobias. All right, questions about social anxiety or social phobias? All right, I mentioned, I think, last time that obsessive compulsive disorders probably, has anxiety components, and it gets kind of categorized or connected to anxiety disorders, but it's a little bit separate because there's this thought process that's going on, a repetitive thought process that people experience, and then they have some action, right, some compulsion from that to help them modulate that or make them feel better about it. So the numbers are pretty high. The numbers are probably higher than we know because people don't tell us about them. So it's a pretty secretive thing. If an individual has an obsessive compulsive disorder, they know they have it, and they assume that most other people don't have it. So they don't want to confess that they have this problem because they don't think it's normal or expected, and they're somewhat fearful about that, how that'll be taken by their family or by anybody else outside of themselves. And so they don't talk a lot about it. They don't get into disclosing that. So it's very secretive. Kids and adolescent population, the child and adolescent population, they have a different capability because they don't always know that there's something wrong. They just know what they do. I have an old book in my office, a manual called Kissing Doorknobs. It's written by a lady, it's out of print, but written by a lady who, as a kid, had obsessive compulsive disorder, but it was at a time when people didn't recognize the disease state too frequently or too commonly. She knew she had this weird requirements every day getting to school. She was always late to school because she had to do certain things to get there in the process, and she'd have to start over from home again if she messed up something in the process of getting there and the procedure. And the teachers in the school eventually just, accepted all that. She would be late most days. That was okay. Her friends kind of accepted it. Her parents and family thought she was weird. They told her she was weird. And so this went on for some time. One day she's at home, and her dad did some business out of the home, and a guy came to do some business with the dad. And this guy had been a teacher before. And so he saw her doing something. It is called kissing doorknobs for a reason. Doing something unusual. I don't know if it was kissing doorknobs at the time, but something that was not expected. And he watched her for a bit, and then he told the parents or the dad that, the daughter has something wrong with her. She actually has a disease state that can be treated, obsessive compulsive disorder. And so they eventually got treatment. So she was talking about, in the book she talks about as a kid, what her perspective was, but she didn't know anything was wrong with her actually. She knew something was different about her, but she didn't know that was unusual or unexpected. In adults, though, adults usually know that that's not activities and things that other people do so routinely, so they keep it very secretive. So they won't seek treatment until it's impacting their life. So if it's a cleanliness issue, showering, getting ready for work, it just grows and grows. It used to be a half hour, now it's an hour, now it's an hour and a half, now it's 3 hours, now it's 4 hours, now it's 5 hours, and they get up at 1 o'clock in the morning to get ready to be to work by 7 o'clock or 8 o'clock. So they're not sleeping at all. So those things start to become impactful. One lady I met many years ago, she could not throw away or discard used tissues or Kleenexes or paper toweling or anything out of her house. And so this wasn't too secretive because the family all knew their whole house was filling up with all these things, with these tissues, and she would get very angry and very upset if they were discarded or thrown away. So eventually what happened was the family said, it's either you or the tissues. Somebody's got to go. We can't have both these things in our house. And so that's how she sought treatment. In treatment, eventually, she was not able to discard them, but the rest of the family could, and that was acceptable enough so they could live with each other and without the tissues and other products that she couldn't get rid of. So sometimes it's not secretive because it just involves enough other outward things that people know about them. So it's an interesting disease state, pretty common. A lot of us as pharmacists and healthcare workers, we're somewhat obsessive compulsive in our personality because we want to be exact, we want to not make mistakes, we're very specific about things. And so we get some advantage to that in our day-to-day work, but that can become overwhelming. So probably the largest number of things that students have come to me about over the years is, Dr. Price, I think I have OCD. And we talk a little bit about, well, why, what are the symptoms, what is going on. And some of them, there's a couple I can recall still today that, yeah, probably, we're real close to getting diagnosis. So the big thing is treatment, and that's a very positive thing. There is treatment for it. But we kind of have that within our nature as practitioners a little bit to be exacting. A lot of them do develop other co-occurring or comorbid types of conditions because of this stress and the challenge of that. So depression is not uncommon to develop a depressive episode at least once or if not multiple times. It can overlap again with other types of things, those phobias, generalized anxiety disorder, eating disorders, panic disorders. Substances and alcohol, people start to self-treat, and we see that a lot in anxiety disorders and generalized and in others. People self-treat. They use substances or they use alcohol to help try to control some of the issues they have and self-treat. And some of it works. Alcohol is really a benzodiazepine, so to speak, so it can help them a little bit in that process. But then it brings on other difficulties and other challenges. So again, from a etiology standpoint, serotonin is probably involved as part of the dysfunction or difficulty, but that doesn't always work completely when we try to use those products to help them. So we have gotten into using other things. Sometimes we might use an antipsychotic because antipsychotics help control the repetitive thinking process, and so those kind of stuck in this rut of thinking over and over about something that they know is not real. In this case, it's not a delusional thought like we would talk about in schizophrenia, but it's a repetitive thought. So sometimes we'll actually use antipsychotics to help people out. But mainly we're going to try to use the SSRI antidepressants for the most part. In severe cases, you might do other things like neurosurgery, where they actually snip or clip some of the connections in the brain to help control and limit this thinking process. Severe cases, they'd actually split the hemisphere, so there's no connection between them. There are a few people that have had that done. There are a few people here in Nebraska that have had that done, so their OCD is so significant that they had to do that. The worst case I've ever seen was a hospitalized lady, which is unusual. We don't always see OCD patients as hospital patients. And she was hospitalized because her way back story was she had been a graduate student, I think at Stanford. She was sent to do some continued work in her graduate studies in China. And she ended up living in a place that ended up having a lot of cockroaches and insect infestations for a period of time, maybe 6 months or so she was there. She was not fearful of insects and such when she went, but after having experienced that and spent the time there, she became very obsessive, compulsive about the cleanliness and all that. So after she came back to the U.S. and eventually came back, she's from Omaha, she came back to Omaha eventually, she wasn't able to do anything. She couldn't work, she couldn't because of this cleanliness concern and how her washing rituals and all these kind of things. She would basically just lay in bed. So she was living with the parents. Because she was laying in bed all the time, she ended up developing decubitus ulcers on the backs of her heels, like people with diabetes do. And so she had to go to have surgery on both of those. And eventually the surgeons said they could not close the wounds permanently. So that meant that she was going to have this wound care process really forever. So eventually the parents, she went back home, and after some rehabilitation time, the parents became very stressed, the mom in particular, because she was now like probably in her 35 maybe, and she had been there for a number of years, 8+ years maybe in their house. And so it got overwhelming, and one day the mom calls the ambulance telling her that they needed to go back to the hospital for this wound issue, which wasn't true. She was taken to the psychiatric unit, and so we spent a long time. I think she was probably with us for about 2 months. She had all this ritualistic stuff about, eating and everything had to be just right. We had to put her in our room initially. We had put surgical cloth over the table, and she had to eat with latex gloves on. And so we were trying to break all that cycling of stuff, those things that would happen. We hired a specialist, a therapist who had treated people like her before. We hired a temporary person to come in and do that. After about 5 days, he quit. He said he could not help her. So then we organized our own, the team organized their own treatment process, which included having a psychiatric technician with her all the time during the day in particular, and kind of a coaching process. Don't do this, think about these things, whatever, something else. So eventually it evolved where we got her to at least sit out with other patients and eat whatever. She would wear the hospital gowns that we had at the time because she actually had no clothing. She had been at home such a long time, she really didn't wear clothes at home because of this whole contamination concern and whatever. So for a very long time, over this long course of time she was there, she was always wearing hospital gowns. One of the first times I came across her was I was walking in the hall, and I had my white coat on. And she walked very difficultly because of this heel problem. So she kind of walked like Frankenstein, actually. She had kind of a stiff, she put her arms out because she was afraid she would fall, and she would kind of walk stiffly. So I come walking by, the tails of my coat flap against her gown. So I didn't think anything. I went on. I came back an hour or two later to that unit, and the nursing staff said, "Thank you. She spent 3 hours in the shower after your coat touched her gown because you contaminated her gown." She never liked me because later on, actually, we were doing med education group, and we kind of circled the chairs in the open unit, and the students had gotten that all lined up, and then I sat down, and I see her coming. She's coming in the back area, walking along, and there's tables over here, and her lunch was over here. She, for some reason, had not eaten her lunch yet, which we had gotten kind of beyond the eating in a special room and all that kind of thing. So I see her. She's staring at me the entire time. Like, okay, why is she staring? I'm sitting down, I'm moving towards her, I'm not anywhere near. And then she eventually comes right up to me and says, "You're sitting in my chair." The students had just pulled chairs, but this was her chair that had whatever she liked about that chair. I'm like, "Oh, I'm sorry." So I pick the chair and take it back to her table. And she spent like the rest of the group time sanitizing the chair and the armrests and everything because I'm so dirty apparently. And so it was very frustrating. Those are the kinds of frustrating things we had to deal with her. She ended up being on large doses of medication. I think actually we might have put her on 400 milligrams of Zoloft, which is 200 above the top dosing typically. We also used an antipsychotic on her because we tried to control this process. She did improve enough to leave, but we've seen her off and on at times in years past, but has improved a little bit, but still not able to really leave the house or do anything else and work or any of that kind of stuff. So probably the severest case I've ever seen, but they can be that severe. Most are minor in basis and not in that kind of situation. I don't know if surgery was ever discussed with her, doing some kind of neurosurgery. I'm not sure that was ever a possibility. We never really got that far to talk about that. All right, so genetically, yes, there's some setup probably for some individuals. If you have family members that are more prone or you're more prone to have some of those thinking processes, then genetically there's some connectivity there that it increases the likelihood in individuals. So treatments, again, medications, behavioral modifications, that coaching process a little bit. Because again, they know this isn't real. They know other people don't have this thought. If we asked this particular patient I was talking about, did she think other people had these concerns about contamination and uncleanliness and all that, she knew that other people didn't have that. But to get her away from that constant repetitive thinking about it and then the resultant process she had to make herself feel better about it was the challenging part. So the positive is they're pretty easy to treat in the sense that they'll do whatever you tell them to do to get treatment and get better. So adherence is usually not a problem with people who have OCD. If I tell them they have to stand on their head in the corner 25 minutes 3 times a day, they'll do that if that's what'll fix it for them. And actually they're very simple tools. Actually there's a little pamphlet, I used to have a copy of it, and I don't have it anymore, but that had just very simple tasks, like which is what therapists teach patients. They like put a rubber band around their wrist, and then every time they have a thought, they snap the rubber band. So it's a counteractive kind of process to help teach them not to think about that or lessen the thinking about that. So some of the practices are very, very simple. Unfortunately, in treatment and drug treatment alone, in particular pharmacotherapy, sometimes you only get a 50% reduction of symptoms, but that makes a big difference. If it took the person 4 hours, 5 hours a day to shower and get ready to go to work, and now they're down to 2 hours, that's a huge improvement. I mean, they're usually very happy about that. We would try to strive for 100% remission of the symptoms, but sometimes that's not possible. But we certainly can significantly reduce that. It does help to have both medication and the therapy process on board. Time frame takes a lot longer again, so we're using antidepressant here maybe, but it might take 12 weeks. So we really have to get to good dosing and then spend a lot of time letting it do what it needs to do. Surgery, as I mentioned, is a possibility. Obviously, it has lots of adverse effects. When you separate your hemispheres, you're separating the frontal lobe, and so massive changes in personality and other things are potentially problematic. And once you go in and snip these connections, you can't fix them. So we can't go back and repair them, so there can be some significant impacts there. ECT is not commonly used, but potentially a treatment as well. So looking a little bit more specifically, clomipramine is an old tricyclic antidepressant. It is effective. It does have an indication to do that, to use it in OCD, so we sometimes do resort to using a product that does have that evidence. Has more serotonergic activity than some of the other TCA types of medication, but it's not an SSRI, so we wouldn't categorize it like that. We would categorize it as a TCA. Has some norepinephrine activity. It does impact the liver a little bit more than some of our other products, so we might look at LFTs on baseline, and can do divided dosing, but eventually you can just do once-a-day dosing. It has a long enough half-life to do that. More commonly is going to be used the selective serotonin reuptake inhibitors. Higher doses, as I mentioned, with this particular case I was talking about, maybe not that high, 400 for sertraline, but a couple hundred milligrams would be reasonable in that product. So at the high end of whatever product you're going to use to really see if we're getting benefit compared to depression treatment. We're going to titrate that, though, slowly. We're not going to immediately up them within a very short time to the max dosing. Duration of treatment, somewhat a question. Usually over some course of time, people want to try to stop it, and that's fine. So we would taper them and discontinue that. Most of the time what happens is over some course of time, even if you did the taper slowly, they'll get return of some symptoms, which is fine. They'll come back and say, well, I'm starting to get more and more of the thoughts again and the repetition and the things I need to do for compulsion, so I want to go back on the medication. So lots of times they will stay on for long periods of time. All right, questions about OCD? Anybody watched the hoarding television shows about hoarding? Hoarding is probably a mix of things. It is an OCD kind of condition, but somewhat separate also. When you look at brain scan, imaging scans of people that have hoarding versus OCD, it's not happening in the same part of the brain. So there's some connections there, but some big differences. Most people treat it like it's an obsessive compulsive disorder, though. So we might use, if we're using medications, might use the SSRIs as our treatment point, and then also using a lot of therapy on those television shows, which of course are television shows, so they're making kind of big deal out of it. But a lot of the issues are where they just get more and more stressed, if you notice, as people or other family members start taking out things out of their house or whatever, they get more and more stressed, because that's their coping mechanism with this thinking process, whatever it is they have, is now being changed, and you're modifying that a lot and changing that a lot. You might see similar types of symptoms in presentation of issues in people that have dementia because they hoard for different reasons. It's more connected to their memory problem in that disease state, so we have to differentiate a little bit about what is it that has brought this on. You'll find in that group of individuals, they'll more apt to keep like mail and newspapers and other things that would remind them about things that happened historically because they're having trouble remembering things. So some of it's kind of tied a little bit to what they might be experiencing in another way. Okay, post-traumatic stress disorder. We see lots and lots of patients that have this as a co-occurring or comorbid condition with the other things we see in the inpatient side. They're not usually being admitted to treat PTSD, but it's one of the things they happen to have as a disease state. Prevalence is pretty significant in the U.S. A lot of the patients we see are not related to military service and that part. Some are. Most is to other things. So abuse, being victimized in other situations. So we see it a lot in child adolescent population and then see it a lot carried on into adulthood. So that's where we see most of our PTSD flashbacks and re-experiencings and nightmares and intrusive thinking that's coming from those past experiences that happened earlier in their life, unfortunately. Again, comorbid conditions are co-occurring, so depression is common. Generalized anxiety disorder is not uncommon as well. And then they can have lots of other things too, but probably depression and other generalized anxiety disorder are pretty significant in presentation. We talk about, again, pathophysiology, so this central dopamine and noradrenergic system being improperly fired up, so to speak, and they get into these hyperarousal states, so they're very stressed by the environment around them because they don't know what's coming, actually, so to speak, so they're really keyed up too much, which again is problematic in a lot of our anxiety disorders. There's too much of this hypersensitivity or this fight or flight kind of phenomenon that's just milling along, and that just keeps them revved up every day. So they're very quick to respond to noises or to lots of activity. If there's lots of people moving around for some reason, whatever, they usually do not enjoy those kind of situations because they feel very threatened by that. They're so responsive or quickly responsive to those types of situations. So treatment-wise, we're trying to decrease some of those target symptoms, the repetitive thinking that they do have, the re-exposure, so they kind of have these re-experiences while they're awake. They kind of go back and live in those situations. They'll get a lot of physical symptoms. If it was something that was so stressful physically that they were running or whatever, they'll get increased heart rate, shortness of breath, those types of sweating, those types of symptoms. So we're trying to control those target symptoms and decrease some of that re-experiencing component and some of that intrusional component. Very important in PTSD is having some other non-pharmacotherapy treatments. So cognitive behavioral therapy, other therapy methods is really one of the big components we can't oversee and forget about because it does impact in improving their disease state if we have that involved. Does take, again, a lot of time to get good benefits. So, 10 weeks or so is a reasonable time frame once you got to appropriate dosage to wait to kind of see if we're getting some benefit. We know a number of meds are effective. The SSRIs, TCAs, and monoamine oxidase inhibitors in particular are very helpful. SSRIs do have FDA labeling for PTSD treatment. We use a lot of augmenting medications at times. So one of the big ones, which you should highlight a little bit, is prazosin. We use that a lot to help with the nightmares that people have. So they have a lot of difficulty with sleeping, and they have nightmares and intrusive components of that. And so we use small doses, usually 1 or 2 milligrams kind of start, can titrate up. Again, you don't need to know the doses, but titrate up a little bit there, and we use it at bedtime. So we can reduce some of that. You will find some people on it during the day as well because they have a lot of intrusive, repetitive thinking that they go through and those re-experiences, and so they are reduced somewhat, especially if they have a lot of the physical components of that presentation. So prazosin is used pretty heavily. We're using it a lot. There's supposed to be a product that'll come to market, specifically marketed. Unfortunately, that means it'll be expensive compared to what we have available generically for the product today. Biggest downside is it's an antihypertensive, so lowering blood pressure or decreasing heart rate too much for individuals that might not be able to tolerate that. Other products, anticonvulsants, so things like Depakote, which we've talked about, possibly carbamazepine. Some of those products we've used off-label for assistance in treating PTSD patients. Using anxiolytics, things like buspirone might be a possibility. We might use also antipsychotics to help reduce, again, this repetitive thinking process. And there are a number of studies about that. We've done studies here with the Creighton Psychiatry Department, specifically of specific types of patients or victims that have PTSD, and then what's the result using an antipsychotic. So there's some good data out there. None of the medications, however, indicated to use in that environment or that situation at this point, and I don't foresee any really getting that kind of indication. But we might need to use that level of treatment. One thing of note here, hopefully, that you've seen is there's not a benzodiazepine listed. So benzodiazepines are contraindicated, basically, in PTSD. We should not be using benzodiazepines. They're not helpful. If a patient's on scheduled dosing and withdrawal from the benzo, they'll get a recurrence or rebound of massive symptoms of PTSD, typically. So we discourage using benzodiazepines in PTSD. Having said that, you'll find lots of patients on them, but they really should not be on them. This group of people is certainly a group that self-treats, so they frequently have alcohol problem, frequently have other substance problems because they're trying to control all those symptoms. So another big reason why they should not be on benzodiazepines. They're already doing some of that. So a lot of these people are in co-occurring kind of treatment scenarios where we're using medications for the PTSD as we can and the group therapy, but we're also treating whatever else has been going on, the substance use problem or alcohol problem. So benzodiazepines really should not be used in people with PTSD. In terms of duration of therapy, not a lot of good information there. A year to 2 years of continued treatment is reasonable. Sometimes it'll go forever, long term, if people are willing to do that. Most people do get a pretty substantial reduction in the symptoms, not always 100% again, but the improvement is so drastic that they'll be happy to get what they can from the treatment process. So we really need to keep it on board as long as possible. And most people are willing to do whatever, again, in this disorder to be adherent so that they continue to feel as best as they possibly can. All right, questions about any of the anxiety disorders? Just look at slides a second here. I don't think there's anything that's too significant. Any questions? Okay, I think next we're talking about eating disorders. I think with this group, the PowerPoint's exactly the same pretty much as the Word document, so you can use either one. So eating disorders, in the inpatient side where I work, and we don't see these too often, yesterday, I had the students on rotation watch a video about eating disorders. What gets patients into the inpatient side is one of two things. One, they have a co-occurring, they have another disorder, which is very common. So they have depression or anxiety disorders or a combination of things that gets them to the inpatient side for a psychiatric treatment. Or they have medical complications of their eating disorder, and that gets them into a medical ward or medical treatment area, and not necessarily in psychiatry. So most of their treatment is outpatient, that they're getting that treatment in an ambulatory setting, not inpatient. I do have some very significant cases that we see over time that frequently come back into the hospital. Usually for a combination, they have other co-occurring problems again, so that gets them into psych. It's not necessarily their primary reason to get in is because of the eating disorder, but because of other resultant conditions they have, they get into that situation. And we might actually be doing some forced feeding and some other things in those situations and do nasogastric tube feeding and those types of things in some of the individuals. So we're going to talk primarily about the two main disease states, anorexia nervosa and bulimia nervosa. There are other subs and subtypes, but we'll talk about the big ones, so to speak, and apply our thinking to those in terms of treatments and other options for management. So some definitions there. Anorexia is that lack of willingness to maintain a minimally expected normal body weight or expected body weight. And on top of that, they have an excessive concern about that. So they don't want to gain weight. They don't want to maintain that appropriate weight. And even though they are underweight, they don't necessarily see themselves like that. So if we have individuals stand in front of a mirror and tell us in therapy what is it they're seeing and what do they see there, they're not going to say that they see a normal image of an individual in terms of weight or body composition. There can be subtypes, so restrictive subtype is pretty common. That means they're restricting caloric intake, so they really minimize what they take in. Sometimes they'll eat very small amounts of food over a number of days. They might have ate an orange last week, and that's the last time they've eaten anything. That's not uncommon. They can also, though, have binge purge type, so they do binge sometimes on food items and caloric intake and then purge that. So they kind of transition. I'll talk about in a minute. There's usually some transition over a long course of time between the two, so they kind of get blurry. Some people that had started out anorexic get a little bit more bulimia, and people that start bulimic sometimes get a little bit more anorexic, and they cross back and forth a little bit. That's not uncommon. Bulimia nervosa is more the binge component, so they're binge eating, followed by the compensatory induced vomiting. They do some fasting afterwards, so they might take on 20,000 calories and then fast for a day or more, sometimes instead of doing the self-induced vomiting. They get into other things, ritualistic things, excessive exercise, and they use things, misuse products, laxatives, other things to help control their weight, diuretics if they can get a hold of them to help reduce fluid weight. Anorexics do some of that as well. There are some that only purge. They don't really binge, but they purge quite a bit. There are those that binge but don't purge. So there's different subtypes there. The difference in bulimics to anorexics is from an outside picture, they look pretty much expected weight. They usually don't look overweight. They don't necessarily look underweight. They're pretty close to what they should be. If anything, they might seem a little bit heavier than their expected weight. And then lastly, that perception in weight, perception in body image is distorted. So they think something is different or their image is different than it actually is. Interestingly, they can pick out other people and say, well, this person's overweight, that person's skinny, whatever. But in themselves, they don't see that. They see themselves one way, and it's usually an opposite of what it really is. Numbers game is probably a bigger number than what we know from epidemiology studies, just because a lot of secrecy in eating disorders, a lot of hidden things that people aren't seeking treatment, so then they're not counted. Somewhere around 8 million, it's probably higher, 12 million plus in the U.S. today that might be affected by either one of these types of eating disorders or eating disorders in general. Younger groups of females are the group that we kind of account for the bigger number typically. And it goes back to the image issues and body image and perceptions that come into play that impacts that quite a bit probably. It's not just about the individual though. There are family issues usually. Their family core has some significant issues, a lot of enmeshment, meaning that there's a lot of connectiveness to people, mom, dad, or both. There's a lot of controlling issues. Do this, don't do that. A lot of really close observation in the family, of everyone in the family, and pointing out things that could be better. A lot of critique, so to speak. A lot of connectedness. Overprotectiveness is sometimes described. Very rigid about rules or things that happen in the family. And then ultimately, there's just a big lack of conflict resolution. They're not able to, in the family, resolve issues that come up very well. Their method of doing that doesn't work out very efficiently, so that's not uncommon. And then the drug and alcohol abuse or substance use is very high, especially in bulimics. They have a tendency to misuse lots of different things, including illegal substances and alcohol. So they're trying to manage in some ways some of the problems that they have, but that's not completely representative of what's going on there. But they do get into use of those products. So lots of theories. This is a psychotherapy, a psychological theory of what might happen here. So it's called a control theory. So individuals that lack self-confidence, they lose that control they have or feel like that, and so they find relief by starving, because that's something they can do or modify potentially, and nobody else can force them to eat or control how much they exercise, or not readily able to do that, and so they feel some control through that. So this is kind of a vicious cycle here. So at the bottom, personal ineffectiveness, increased fear of loss of control, so then they start starving and move to that side. When they start starving, then they decrease their concentration and decision making because they become hypoglycemic, they don't have proper nutrition. One thing that we know happens in eating disorders is that in treatment side of it anyway, in particular with the medications don't work lots of times because they don't have the basic building blocks to build the neurotransmitters. So our medications can modulate those, but there's nothing to modulate because they don't have them. So nutrition is a big component of this, and it contributes to this vicious cycle of events. So as they continue to do that, so then they get this lack of decision-making and concentration capabilities and functionality, and then they feel ineffective again. They feel more loss of control, and they just continue this cycle of events where they keep trying to do it this way to get into control. So very complex interactions here, probably from a pathophysiology standpoint, neurotransmitter management imbalances, hormone balances, peptides and communication pathways are impacted. And this is a complex process of controlling hunger, satiety, and eating behavior. So it's a very basic thing in lots of ways, but lots of contributing things can come into this that really impacts the individual related to the disease state. We know serotonin plays a role in satiety or feeling full, so that's one reason why we attack that in terms of treatment options is using a serotonergic type of agents. But also norepinephrine is a base stimulus for eating behaviors. So when you see wild animals eating whatever, and there's other animals, they get very angry or frustrated with anybody coming near that they're going to take their food. That's a very basic norepinephrine-driven type of phenomena. So we know that that process is part of this as well, and there could be some defect, if you will, or some dysfunction there that we need to try to manage. So clinical presentation for anorexia. Demographically, these are middle class to upper middle class individuals from a socioeconomic standpoint for the most part. They're usually from families or part of families that are highly successful, have a lot of demands on the family, has a lot of demands on children and high expectations about them performing very well or doing very well at school or sports or other things that they might be involved with. They do have this image perception issue, so they can't perceive that properly. They cannot tell you whether they seem appropriate or not. Body weight focus, lots of that. Again, dysfunctional family in the sense of difficulty with conflict resolution. And the control then for food intake and caloric intake is very common. Comorbidly, again, lots of things. Depression, obsessive compulsive disorder, anxiety disorders in general, kleptomania, stealing things they don't need, shoplifting, those kind of odd symptoms sometimes people present with is not uncommon in anorexics. And then fear of specific things, fat in particular, they can always tell you exactly how many calories are in something. You don't need a book or guide, you just ask them. They know exactly how many calories everything has, how much is fat, how much is protein, how much is sugar, so they know all of that. Again, so by definition, in DSM criteria, which hasn't changed in 5 really, maintaining or refusal to maintain a body weight over a minimal normal weight for age and height, cannot gain weight as we might want them to, or during periods of growth they don't gain weight, and they usually have body weights 15% lower than expected normal weights for their age and height. They have that intense fear about gaining weight, becoming overweight or fat, and they may be significantly, obviously, underweight, but they don't perceive it that way. And then again, the self-evaluation is not accurate. In females, lots of times they will not achieve their puberty milestones because they're not achieving it because their body weight is not high enough. Their body fat content is not high enough, so you usually have to be at least 15%. So we might refer to this as Peter Pan syndrome, not wanting to grow up. And so lots of times when you see a group of individuals in anorexics in particular in an eating disorders treatment program, the ages of the kids in there are a lot older than they look because they've actually never achieved puberty. So they look a lot younger. So it's an interesting phenomenon. They want to be in control, but yet they really don't, actually. They don't want to grow up. They don't want to be responsible for what they need to do as a maturing individual. They don't want that. So it's a very ironic kind of concept that they want to be in control and they choose to be control in their weight and their nutrition and taking in calories, but they don't want to be in control of anything else. They really don't want to be put in charge of themselves. Again, subtypes, as we talked about a little bit, they can vary back and forth a little bit. They do misuse products, both anorexics and bulimics, but anorexics do that too, in particular for control of water weight. And then they kind of go back and forth, so not uncommon. All right, let's take a break here and we'll come back and finish up eating disorders. Okay, let's get started again. Any questions? Okay, so I referred to this graphic a few minutes ago. So there's a little bit of crossover eventually. So more pure anorexia on the left and bulimia on your right, and then there's some overlay of some of the symptomatology between them, and those things can kind of cross back and forth in individuals, and they get a little bit more towards the bulimic side or towards the anorexic side, depending what they started with. So again, anorexics having the issues with caloric intake, hunger, satiety dysfunction. People will say that anorexics aren't hungry, but that's not really true, actually. It's not like they learn to justify that or get past that. They still have a hunger-related feelings and concerns. They just don't abide by those. They don't eat. Excessive energy and exercise can happen in anorexics. Sometimes it's almost like a delusional thing, or they don't, again, see what's going on. We've had patients on the inpatient side where we're rounding on them and come by and talk to them and say, please, can you stop doing, ab crunches for a few minutes so we can talk? And then they're just like, what? I'm not doing anything. Yeah, you're doing ab crunches. Let's stop that for 5 minutes while we talk to you about what's going on today. So it's almost as if they don't perceive that, as well as not perceiving the proper or respective body image issues. Again, this ineffectiveness, sense of personal ineffectiveness, sleep problems. Sleep is a problem, as we'll talk about shortly, because they don't have neurotransmitters. They don't have some of these neurotransmitters they need, and sleep is a balancing process. And you have to have some of these neurotransmitters. They don't have them, or they don't have appropriate concentrations of them, so to speak. So it's not uncommon for them to have disturbed sleep or insomnia process. Problems. Loss of menses, we talked about that for the females. Sometimes they have not had a period for 5 years, depending on where that body fat content has been. Socially withdrawn, sometimes keep a lot to themselves. Again, they think that they're the subject of ridicule, or their perceptions are that others feel that way as well, and so they stay out of the public eye. Usually look very emaciated if you see them. Dry, cracking skin, discolored skin is not uncommon. They have a very fine kind of hair, sometimes called downy hair. I'm not sure what that means, but once you see it, you know what to look for and what to see. I've been just publicly on an elevator or whatever and see someone in the elevator. It's like, oh, that lady has anorexia. It's pretty obvious, usually not just from body composition, but by the hair or skin. There's some pretty obvious things in severe types of patients. So again, this center part is a lot of overlap. They can have these on either way or chart to trend one way or the other. You'll see some things down here about perioral dermatitis or peripheral edemas, so some difficulties with managing fluid status because of their physical situation and their electrolyte balances. EKG changes, so a lot of people end up dying medically from these complications because of their malnourishment, is what brings on a lot of those issues. Anemia obviously makes sense. On the bulimia side, again, more of the overeating part and compensatory purging. A lot of secretive eating, so they'll stash food away to gather up large quantities to eat later on. Have a tendency to eat high carbonate fat and carbohydrated foods. The video had students watching on rotation yesterday. There's an experiment where they put an individual that has bulimia into the room, and they put all this food out on a table. Includes all sorts of fun things like Oreo cookies and bags of chips and ice cream, all this stuff. And then they let the person sit in there for like a half hour, and then they show the after. So they take video before and then the after, and it's amazing how much can be gone in the time frame. There's probably 25,000 calories worth of food on the table, and that one individual in a half hour will eat, 18,000 calories of that or whatever, so pretty significant. You would think there was a big party and a lot of people came in there, but that's not the case, so they will consume large quantities. Bulimics have frequent weight changes or swings, so to speak. They are, again, secretively using laxatives and diuretics to get some control or help with controlling. They do have impulse control issues. That's where this kleptomania part comes into play. So they don't need to steal things or shoplift, but they do it. They have some issues with impulse control. It also is part of the process of overeating, eating these large quantities of calories because they just can't control the impulse that they might have to do that. In process, then they can get into some other difficulties, gastric rupture, pancreatitis, so they get inflammation of their parotid glands or their saliva glands because they're always bringing up stomach acid, and that's irritating those. They can get cancer even from in those glands because of that. Sometimes the first person to notice that a patient has an eating disorder is the dentist because of the erosion of from the acid that comes up into the mouth to the teeth. It causes significant damage. These individuals do have self-mutilization issues. They have a tendency also to sometimes have personality disorder embedded or overlaid into the condition that complicates that more. And those individuals sometimes are self-mutilators. Suicide attempts are not uncommon. Otherwise, they look to be more socially outgoing compared to their counterparts in the anorexia world that are a little bit more socially withdrawn. So medical complications of anorexia, amenorrhea, osteoporosis, because they're not taking inappropriate consumption of calcium, and then the other necessities nutritionally to maintain their bone mass. When you look at images of individuals that have long-standing eating disorder or particular anorexia, you see some massive changes in their bone density, even over short periods of time. Other types of decreases in issues, hormone issues, other controlling issues, things related to their body temperature is not maintained properly, so they have great difficulty. One lady we've seen for many years, she always wears this big, long, massive winter coat. Even if it's 95 degrees outside, she's going to be wearing that coat because she cannot maintain her body temperature. She only weighs sometimes around 65 pounds, and she's 5'6" or so way below her expected weight. Bradycardia, so a lot of cardiac issues again, hypotension, arrhythmias are very, very, very common. And again, that might be what actually kills them in a sudden death process. Changes in BUN, renal function obviously is off. Edema, again, because they don't have proper osmolality, so there's not enough to pull back that fluid into the bloodstream so it can be managed better. So that balance of electrolytes to tissues and to the venous system is not proper, so they get peripheral edema. Their legs might look huge, actually, or their hands, because they don't have the capability to properly manage that from a fluid management standpoint. You get changes in other things, white blood cell counts, thrombocytopenia, again, because of the malnourished situation that they're in. So treatment goals, they do need to be hospitalized if they have a significant or rapid weight loss, and it's greater than that 15% of body mass. Usually they're hospitalized because of those medical complications. They started having palpitations or syncopal episodes or something that brought them in. The other thing outside the medical part is the suicidal ideation, the plan, the attempt, so they have a lot of suicidality. It's really what, in the end, if the medical component doesn't kill them, then it's the suicide that does. So the opportunity for and the potential for suicide is significant, and the majority of patients die from suicide, actually. They commit suicide or complete suicides. If they've not been responsive to outpatient treatment or ambulatory treatment over a number of months, or continue to be poorly motivated to help themselves, so to speak, and be part of that treatment process, then again, there's reasons for them to be treated from a safety perspective in inpatient unit, even in a psychiatric unit. Those continued family problems or completely dysfunctional family issues that come up would drive them into get at least some short-term inpatient treatment. And again, anything that requires to be observed and prevent purging and do those things. So patients on the inpatient side, their bathrooms would be locked, so they can't easily purge and do that. On occasion, we might restrain someone if we're forcing them to forcing a peripheral IV line or even a total parenteral nutrition feeding. We might have to restrain them to do that. In individuals that are below legal age, the guardian is consenting to that, so mom or dad or somebody else is doing that. They're not doing it willingly, but sometimes we do have to do that. So what are our goals of treatment? Reduce that distortion of body image, restore and maintain a healthy body weight, reestablish normal eating patterns, and then work on those associated psychological and physical problems, and then a lot of work on the family issues. And ultimately preventing relapse. So the first goal is to get people to eat properly again and proper nutrition and get back to some expected weight. And again, if we're not getting back to that, we're not successful. We're not really getting the treatment we need to get. So a lot of the focus on treatment is going to be about nutritional rehabilitation and consulting with nutrition experts and dietitians that are experts in that, and people that work specifically with eating disorders, and then therapy related to that component as well. So that's what we're going to focus a lot on in treatment. Eventually you would get to doing family therapy and those components, but obviously, again, family is part of the problem, so you can't attack that right at the beginning. If you try to attack that at the beginning, it's just going to make it all worse. They're going to, withdraw from whatever's going on. They're going to get back into this continued cycling about who's in control, and so you're really worsening that process. you might not get to this conflict resolution or family therapy for years into the treatment process. It's not a primary thing that you're going to work on. Eventually, yes, it's one of our goals, but it's not the first thing you're going to try to attack, because that will not work out for the positive. Prognosis is poor. The 5-year rate, so individuals that first are identified that have a significant eating disorder, or anorexia in particular in this discussion here, 5 years out, a very significant number have not survived 5 years. Again, because of complications and medical issues, or because of suicide. So the prognosis is the worst, actually, in the psychiatric illnesses. The prognosis for living life at the expected endpoint is poor. Their morbidity is high. Again, non-drug treatment, not necessarily in any particular order here, but behavioral management, cognitive behavioral therapy, working through, again, how to manage stressors, how to be more in control, so to speak, in a better, more appropriate way of doing that. So interpersonal psychotherapy, nutritional counseling, again, if we're putting these in some order, that nutritional counseling or rehabilitation from that perspective of eating would be at the top. That's kind of the primary thing we're going to do. And then group and family therapies are later on. Sometimes in group therapy, in terms of groups of other eating disordered individuals, they kind of learn from each other bad things to do to continue their disease state. So you have to be careful about group therapies, because that's not always a positive in helping them. They form some competitions, who can be thinner. I can be thinner than that person and this person, and so they get into some competition. So group therapy is not always working. In terms of setting some kind of goal, we're looking for some kind of weight gain. A better method, though, is to use caloric management. So if the individual's only eating 300, 400 calories a day, we set small goals. Well, we're going to start trying to get you to 500 calories of intake now. And that'll go on for some period of time. We're not going to go day by day increasing by 100 calories or whatever. We're not going to do that. But over a long period of time, we're going to set small goals, and they will not achieve them most of the time. It'll take, again, a very extensive period of time for them to start achieving that. And through that process, then getting them to appropriate weight. In inpatient settings and in outpatient settings, we do weigh them. We usually don't show them what their weight is, because, again, that's what they focus on. So they'll step backwards on the scale. The scale displays the weight to the healthcare professional in a different way, or outside of where they can see it in their sight line, so they're not able to see what that weight actually is. They check it on their own or kind of know, but we don't show them that. We don't focus on that a whole lot. So drug treatments, a lot less evidence here that these are helpful. And again, probably not helpful because they don't have that basis. They don't have the components to make serotonin. They don't have the appropriate baseline proteins to make communication peptides and so forth. So those things have to kind of build with that eating and normalization of that before you can help them here. Fluoxetine as an SSRI is probably the most studied in anorexics. Does not have an indication again, however. Probably what we're doing many times is treating some of the other issues, again, the depression issue they might have or anxiety disorder they have going along with their eating disorder. And when you improve that, then you improve a lot of what they might have as other symptoms related to their eating disorder. So a more of an indirect type of impact. Tricyclic antidepressants really probably aren't used a whole lot at this point because they're somewhat dangerous. So tricyclics, again, don't have solid evidence, but they've been used a long period of time. If you're going to use them, we probably need to do a baseline EKG because they're proarrhythmic. Remember, they induce arrhythmia even at normal dosages. In individuals who don't have proper electrolytes, their potassiums are off, their magnesiums are off, all those things are off. You can induce cardiac arrest or cardiac event pretty easily, or an arrhythmic event in these individuals. So you have to be very cautious, and an overdose would be very deadly because they can be risky as it is, but in the individual that has an underlying potential for being significant in the arrhythmia area, then this is a dangerous group of meds. So I really don't see these used, but they have historically been used. One reason to use them is because they cause weight gain as a side effect. And so that historically was kind of the primary reason to use them. But again, patients all know that, so they're not really willing to take some of those products because they know that that's what might happen, as they might gain weight from it as a side effect. Antipsychotics have been used, again, lots of times antipsychotics have been used, both the typicals, which are older, and atypicals. Talk more about that when we get into schizophrenia discussion. The thought was it was helpful with the weight control because it causes some weight gain, a lot of them. But the other thing is just this repetitive thought process about their body image and trying to reduce that by using the antipsychotic as an off-label kind of thing. We don't use them routinely. The one lady I mentioned a few minutes ago that only weighs about 65 pounds that we've seen for a long period of time, she always asks me about products like Zyprexa or olanzapine, one of the antipsychotics that cause lots of weight gain. She sees other people and knows lots of people have gained weight on it for other reasons that they're on it. She can't figure out why she can't gain weight on it. So she always asks me. I've tried these other meds. I've never gained any weight with them, and I try to explain to her again that her nutritional status is so poor that she can't build those kind of neurotransmitters that are being acted on by that medication, which contributes in some mechanism that we don't know for sure, but some mechanism to the weight gain. So she's not going to gain weight for that reason alone. And secondly, it's a side effect. So not everybody gets the side effect, even those that don't have the kind of problem she has. But she always asks me about that, why she doesn't gain weight when she takes these kind of medications that cause that kind of side effect. Ciprofloxacin is an antihistamine and a serotonergic product that works only really in the hypothalamus. So theoretically, it can help with satiety and feeling full or not, and so it can help control that. So there have been use of this kind of product over the years to help control that, to help people feel more like they need to eat or feel more hungry, and so therefore they might eat. The results are very mixed, seems not to work well. And when I first started working in psychiatry, we used it quite a bit. Now I don't really see it hardly ever because it probably doesn't really help them enough. Other types of drug treatments, metoclopramide to help with gastric motility, issues that can come on because, again, they don't have, their electrolytes are not balanced and they're not getting good motility. Sometimes benzos are used, but that's somewhat dangerous because, again, this group of patients likes to commit suicide or make suicide attempts, so they were going to try to overdose or misuse those, so not a good idea, but sometimes used. Estrogen replacement is probably mixed results there. Not commonly done, but a possibility. And then lastly, TPN, total parental nutrition. So again, this would need consent either from the individual if they're of age and their own guardian, or a parent or guardian to get consent. So you're really going to put in a central line. You're going to feed them that way. They're going to be very, very opposed to that. More than anything, they're just going to gain weight right away from the fluid intake. It does take a special kind of knowledge base to use TPNs in this population. So even as pharmacists, you have to be very cautious about how much fluid we're putting in our TPN and what the components are, because you'll overwhelm their heart. They're not able to compensate for all that fluid. They still have a dysregulation and poor electrolyte balance, and you can basically cause congestive failure because there's so much fluid. If you do it wrong, you'll end up basically drowning them in the fluid. So we have to be very cautious about that. So consent's a big thing, the practicality of that. And you're breaking down your relationship as the treatment team with the patient when you're forcing something like that, when you're going to strap them down or put in a central line, because they'll rip out the central line. You have to restrain them probably. If they're motivated enough, they'll try to get rid of the line or do whatever they can. And that's true for other feedings. We might use a nasogastric tube and put the tube down and put food through that process, an enteral process. They'll take that out. They'll pull it out with the balloon still inflated. They'll turn off the pump. They do a lot of manipulative things because, again, they don't want to gain weight. So very challenging to manage people in those situations. Treatments about anorexia or treatment of anorexia. Questions? Okay, bulimia, again, some highlights. Secrecy, very common. Many times people wouldn't know that the individual has bulimia because they appear to be what you would expect them to be from body composition, et cetera. They do have a tendency to use or misuse over-the-counter products or other products they can get. So when you're working at, Walmart, somebody brings up a big case of X-Lax, you should be like, "Well, what do you need this for?" Because they do that. They will use those types of products. Serpivipacac is used to induce vomiting, and it was handed out commonly in the distant past, as a treatment for poisonings. And so for kids in particular, sometimes they just be free little bottles. Unfortunately, it's toxic somewhat, and these individuals will use lots of it because they're helping to use that or hoping to use that to induce vomiting. So you don't see, it's not as readily available, and it is cardiotoxic, so in large quantities, so you don't see that as much. But if people can get their hands on it, they'll use that as a way to induce vomiting. Appetite suppressants, whether they're over-the-counter or herbal products or alternative medicines, or if they can get prescription medications, they will do that to misuse those products. They use prescription antidiuretics. They may have their own prescription for that, so they've went to the doctor and some doctor's given them that. Many times they'll steal them from somebody else in the family. So if mom, dad, or somebody else or grandma's on diuretic, then they'll use or misuse those diuretics to control that fluid again a little bit and some of the weight that they contribute to that. Again, their weight is usually pretty much normal. They might go to the doctor or try to get treatment from a vague physical complaint. Oh, I have headaches all the time, or my stomach hurts all the time, or my back hurts all the time. So kind of an odd somatic body-based kind of complaints. And they'll never say anything about their eating issue, but they'll talk about that. Another sign besides we talked about the teeth and how that gets impacted in the dental issues. They also get scarring sometimes on the back of their hand because they use their fingers to induce vomiting. And their gag reflex is such that they bite down on their hand, and so they get scar tissue on the backs of their fingers. Some don't like doing that, so they use other things, the handle of a toothbrush or a brush handle or something else to induce vomiting. Most of them are very good, and they can just vomit whenever they want. They can induce it without doing any of that. They learn what they need to do physiologically to make themselves vomit without inducing it. But those that can't will use their own fingers or other objects to help induce the vomiting. Again, so diagnostically, excessive intake of calories over a short period of time, very sensitive about weight and body image, again, more secretly, but certainly concerned about that. Usually do have close to normal body weight. Binge, it might be once or twice a day or a couple times a week. It might be more frequently than that. At minimum, they probably do it daily and vomit daily, at least once on each side of that. Evidence of binging, meaning that they've kind of hoarded a lot of food products and then go into the bathroom quickly after eating, whatever, even when they're supposedly eating normally. Can consume as much as 20,000 calories in one sitting, so not uncommon for full loaves of bread, bags of chips, whatever it takes, large quantities of calories, again, in a pretty a short period of time. Personality disorders, I mentioned that earlier, they do have those, and then the kleptomania piece, that impulse control issue, and then have lots of co-occurring things, the depression in particular, and substance use or misuse of products. Medical complications, less of the menstrual irregularities in women, but they do have some of that because sometimes their weight fluctuates quite a bit to some extent, and that impacts that. That serpivipacac poisoning, as I mentioned, that it causes cardiac toxicity. Hypokalemia because they use the diuretic, so they're getting rid of a lot of their electrolyte or disturbing their electrolytes. Because they consume so many calories, they can get gastric dilation and rupture of their stomach, basically. They also get, again, that saliva gland enlargement and or damage, the dental enamel erosion problem, esophagitis, because all this acid keeps coming up into their esophagus. They can get other tears and ruptures of their esophagus, and again, hypokalemia. They also get aspirational pneumonia because they're vomiting enough that sometimes some of it gets drawn back into their lungs. So treatments similar to the anorexics, again, focusing on that nutritional rehabilitation and getting that normalization of eating and not doing this binging process or purging process. Treat other issues they have, depression, anxiety disorders, other components that they have would be important to consider. Non-drugs, same. Planned meals, meaning that they're only should be eating when the family's eating or with other individuals. Family therapy, again, is an important component here as well. There's still this enmeshment issue and the conflict resolution issue probably within their family. So that's a component to think about. At some point, we're going to get to that in non-drug treatment, but also going to do those individual therapies to talk about how to better manage stressors. In terms of drug treatments, so a little bit more evidence here, may be related more to the other components, the co-occurring issues that they have, but a lot of different possibilities here. Antidepressants in general can help change the binge eating piece, the vomiting part, and control some of those other things, anxiety, obsessions, the impulsivity pieces, and so we're improving that with those medications. Some of the tricyclics, imipramine, desipramine, have been looked at before. You have to get to good doses, so top end of dosing if you're going to use those kind of products. There's some risks there again because of the potential for harm in overdose, and they do cause weight gain, so people know that again, so they're not too wild about taking those, but certainly can be utilized. Phenylazine, a monoamine oxidase inhibitor, again, has good potential evidence. If you remember, monoamine oxidase inhibitors, however, have a lot of drug-drug interactions or have food interactions. So we're giving them a medication, then we're telling them about restricting dietary things. That's probably not an ideal situation to get into that. Trazodone is an antidepressant, again, used off-label more for sleep, but it has been shown to be somewhat helpful for individuals, so a possibility. Fluoxetine actually has an FDA labeling for use in bulimic treatment, bulimia nervosa treatment, so certainly one of our labeled products that could be used. And we're going to push to the high end of dosing, so again, you don't need to know exact dosing. High end of dosing would be like 80 milligrams a day, so much greater dosage than we would use in treating depression for the most part, or in some of the anxiety disorders, so we're going to push up to the top end of dosing. So again, SSRIs are first line. You could use some of the other ones off-label as well. Probably they can be beneficial. We need to look at some other things related to those products at baseline in terms of their electrolyte disturbance. We want to get that normalized if possible. Remember that antidepressants in general lower seizure thresholds, so there's always somewhat of a risk there of that, and especially in someone that's not nutritionally stable. So we need to look at that a little bit and consider that. Other products like mood stabilizers like Depakote, those products, in particular Depakote or Divalproex, has been used mostly because it causes weight gain. So that's one of its big problems and side effects. Does it really work in an effectiveness standpoint? Questionable whether it really does that or not. So mostly we're trying to take advantage of the side effect profile, which is probably not a good thing to try to do. It doesn't help us out there. Miscellaneous items, TPM, we probably wouldn't get to that in the bulimics, but if they were tipping towards the restrictive side or they were losing so much weight because they're purging so much, we might have to do that to help stabilize their nutritional status. Benzodiazepines, again, might be used, but somewhat dangerous to do that. So primarily the cognitive behavioral therapy, nutritional rehab therapy in combination with some medication if that's needed. So for both disorder duration of treatment, a year is a reasonable time frame, but probably much longer than that. When you talk to individuals that have survived, if you will, eating disorder years out, they'll tell you that every day they still have thoughts about restricting calories or impulses about overeating. And so it's really probably a long-term, lifelong kind of phenomena, and that's going to impact on them on a day-to-day basis throughout their life. So early on, a year is a reasonable time frame, maybe a lot longer than that when we're talking about medication treatments. And sometimes we're treating other types of conditions, so we have to take that into account. That's going along with our treatment for the eating disorder, whatever that happens to be. Questions about eating disorders? So a lot less pharmacotherapy really with eating disorders, usually from the standpoint of the co-occurring illnesses. If we can get some benefits, we have to be more cautious about some of those products because of the potential for the types of side effects or negative outcomes they could get from the medications. And then lots of issues about adherence and the ability to take or willingness to take the medications, if that's part of it. Willingness to do any of the treatment actually whatsoever, whatever it happens to be. So, question? Yep.
When you were referring to the TPN problem, was that because of refeeding syndrome? I don't know if I caught that or not.
So TPNs and the potential for refeeding syndrome, yes, that can be one of the complications. So they're not ready to take on all those nutrients and those components. The biggest thing is the fluid. So you're not going to give them a 3-liter TPN. You're going to give them a 600 milliliter TPN because they're not able to take on that fluid for the most part. And TPNs, if you remember, have to be centrally put in through a central process. They're not put in peripherally. Actually, it's very hard to put peripheral lines in the anorexics in particular, obviously, because they're so dehydrated and clamped down. If you get a line in peripherally, it'll end up bleeding through. It'll end up destroying the line. You won't be able to maintain that. So we can't use peripheral treatments or peripheral feeding. You have to use central line if you're going to do a TPN, or you're using the nasogastric tube, putting a feeding tube in, which they're going to be, of course, very opposed to that. Other questions? Okay. Okay, let's start off on sleep disorders. So there's just a slide deck for this. There is a separate, and I'll talk about that document that kind of summarizes some of the medications. So I'll go over that at the end. So sleep disorders, very interesting. The increase in numbers of people that claim to or have sleep disorder, in particular insomnia, is growing drastically. There's lots of components of that and a lot of components of wellness efforts these days about sleep and sleeping appropriately. You can get tons of different apps on your phone to help you with sleep and monitor your sleep, and if you wear a Fitbit or something else, there's all this data collection about sleep. So there's lots of movements currently about proper sleep and getting as much sleep as necessary that helps people feel better overall. So a very complicated, though, situation when there is a specific disease state. So a part of it, we'll talk a little bit about the dysomnia, sleep apnea, as other types of disease states, narcolepsy, and limb movement disorders. We'll talk a little bit about stages of sleep. Not that I need you to memorize all those, but you need to recognize that there are normal stages of sleep that people go through. Talk a little bit about neurochemistry of those, and assessment of patients with sleep disorders, so we're getting good information or data as we're deciding how to treat that if it's true, and then come up with those treatments and specific issues that need to be treated and disease states that need to be treated as sleep disorders. So again, numbers are large. Part of it's just the way we are today and what's going on culturally and in our society. People sleeping next to or on their phone, and all the bright light theories about how that impacts their sleeping and interrupts sleeping and makes a big change to that. So that's significant. A lot of people that do have sleep disorders have other chronic disease states, either connected to or intermingled with or part of their sleep disorder, or the sleep disorder came after some of those things, or maybe came as part of the early stages of other disorders. So we need to look at that and pay a lot of attention to sleep. We pay a lot of attention to it in psychiatry. So on inpatient rounding every day, we get through a report of every patient. How much did they sleep last night? How many times were they awake? Did they get up in the night? Did they do whatever? So we're looking very closely at that. In my units, it's kind of hard to sleep because every 10 minutes the staff comes in and shines a flashlight in your face to see whether you're awake or asleep. So some people can't tolerate that, so they end up being awake a lot. Okay, so sleep cycles, you're familiar with this, probably somewhat, REM versus non-REM sleep, but these are normal stages of sleep, and we have to get through those in order to get enough sleep, and then the quality of sleep has to be appropriate. So it's one thing to say, yeah, I slept all night, but people say, oh, I didn't feel like I got rested. Well, okay, that's probably a quality of sleep issue. So the time was there, but the quality wasn't, or they just don't get any or enough. So there's a couple different ways of thinking about that and considering that. So those stages are important as we go through a non-REM sleep. and what's going on in your brain a little bit. Those REM sleeps are dream-based, so that's we don't really know the purpose of that, why REM sleep is necessary, but the realization that from a physiology standpoint, you have to go through these stages and cycles in order to get good quality and durational sleep. And you go back and forth between those, as you're aware, over time. This changes a little bit with age, so young adults spend 75% of sleep in non-REM sleep and 25% in REM. Elderly change a little bit in their delta sleep stages and REM sleep and total sleep time. So, if you have elderly relatives or grandparents, they get up at 4 a.m. It's like, why are you getting up at 4 a.m.? That doesn't make any sense. But part of it is just because of their sleep architecture now has changed a little bit physiologically as they age, and they have a different need for sleep and a different type of sleep. That doesn't mean it's not normal or expected. It just changes a bit with age. I don't expect you to memorize all these, but understand that there's this cycle and stages that have to occur for quality sleep and durational sleep. That's what would be expected or appropriate. So neurochemistry or etiology, so very complex process in a very global sense. What's happening is, should I sleep or should I stay awake? The brain this battle is going on all the time. Sometimes it goes on more in this class than other times, but should I go to sleep or should I stay awake? And so there's a very, very complex structure and process that happens. So what that means is there's lots of potential for error to occur or for disease to occur or something that impacts that balance, and that causes either a short-term sleep disturbance problem or a much longer sleep problem. So in the brainstem, hypothalamus, these neuropeptides and these other balancings of neurotransmitters going on, forebrain, thalamus, cortex. So not just one little area of the brain, but the broad section and cross sections of the brain. And then all these chemicals are involved: norepinephrine, dopamine, acetylcholine, histamine, substance P, corticotropin releasing factors. So those are things we know of. There's probably other subtypes and other neurochemistries that are part of wakefulness and managing all that. And then in the sleep slide, the GABA complex and GABAergic situation is impacted. Adenosine, serotonin, melatonin, you've heard about all those things a little bit. So a very complex process, and it wouldn't take much to upset this, either on a short-term basis again or a longer-term basis. So we're going to ask questions about sleep patterns compared to, the past, what's happening now, what happened, 2 months ago, what was going on in the past, if you had appropriate sleep or not, and look through those causes. So situational issues: is there new stressors at work, financial stressors, relationship problems or conflicts, what other management of events in life, jet lag, shift work. All those things can impact sleep from a situational standpoint. If we can identify those and try to modulate or change those, that can fix the problem in itself without doing anything else. So we need to look at that. Medically, cardiovascular, respiratory diseases, pain problems, hormonal-based disease states that have come on, gastrointestinal problems. I mean, if you have an upset stomach, you don't sleep that night. You've got a lot of upset issues that keep you awake. Neurologic disorders, Parkinson's disease, movement disorders, all those things can impact medically on sleep. Pregnancy impacts sleep for a lot of reasons, hormonally and weight change reasons and fluid management changes during pregnancy. So we need to look for these causalities as well. And as we talked about it psychiatrically, we know that bipolar disorder, a lot of people that have mania don't sleep, or hypomanic symptoms, they might not sleep a lot, so that starts disturbing that. Depression, differences in people sleeping too little or too much, so we need to look at that as a basis. Anxiety disorders can impact sleep and decrease sleep. And substance use, so alcohol being one example, disturbs sleep. It impacts those sleep stages. Even though some people use alcohol to help them sleep, that's a negative thing. It's not helping them sleep, it's making it worse. Pharmacologically, again, look for those problems. Anticonvulsants can keep people awake or impact that. Adrenergic agents centrally, diuretics, because they have to get up a lot to use the restroom. SSRIs or antidepressants, if they're stimulants and they're taking them at night or whatever, that can impact that sleep and not going to get to sleep as it's impacting that balance. Steroids are very impactful to sleep, so even prednisone, and in the burst treatments that can impact on a short-term basis, and then any other kind of stimulant. So people that take stimulants for ADHD treatment or ADD treatment, or you misuse stimulants, of course, that's going to impact their sleep. So we have to assess the patient from what's happened and what's happening, and then other causes of what they're getting into today. So non-pharmacologically, one of the first things you might do even as a pharmacist is talk again about what they're doing in sleep, what's related to sleep, and then those things that they need to do in order to get good sleep and to ensure that. So keeping the sleep environment in a dark environment, comfortable, meaning temperature-wise. During those sleep stages, at some point you dysregulate your body temperature. Your brain's not controlling it very much. So if you've ever woken up and you're really cold or you woke up really hot, that's because there's some dysregulation that goes on with the hypothalamus and the management of your body temperature. So it has to be comfortable, not too hot, not too cold, somewhere that seems reasonable. Quiet, not a lot of other distractions noise-wise. Having a regular sleep schedule, so going to bed same time, getting up at the same time. So tomorrow morning, Saturday, and you don't get up at noon. You get up at 7 or 6 or whatever time you normally do is what you need to do on a regular basis. Avoid naps unless you have some other conditions. We'll talk about a few that the naps are helpful, but otherwise naps it's impacting your total bank sleep time basically. So we all kind of have a time frame, a bank of sleep that we need. When you're adding to that by napping, then that's too much. You're not going to sleep through the night or get to sleep easily because you overslept your bank. You don't need all that sleep. We get that in our patients in the inpatient side because they are bored or whatever, and then they sleep, and then we get reported in the morning that, well, the patient didn't sleep all night, but we found out that they slept 2-3 hour naps during the day, so that really impacted what their sleep was for the night. No mentally strenuous activities in bed, so not on your phone, not on your computer, not watching TV while in bed or just before going to bed. Those are impactful things that happen. Avoiding exercise before bedtime or eating big meals before bedtime are all things we need to talk about or think about and guide our patients through that process. I was consulted a few years ago from an outpatient for a guy that had a lot of medical conditions. He was only like 40, but he had 3 MIs, had bypass surgery, had COPD, had bunches of medical conditions. So that was kind of the first big problem with his sleep. As I talked to him, I found out that, and his wife was with him, that he didn't work because he had all of these medical issues and was on disability. And all day long, while she was at work, he would just lay around in their bedroom, and they had gotten or bought these room darkening curtains. And so he would just lay around, watch movies, sleep half the time, whatever, and then he wouldn't sleep at night. Well, this is obvious. Stop doing that. I mean, why are you doing that? So he would be up all night or awake all the time, and it made no sense. So my easy consult was, okay, just change all that. Stop, stay up during the day, go do whatever. He could do something. So we talked about him going back to volunteering. He had done some of that before. It's like, okay, do things during the day, activities. Don't stay laying in your bed watching movies. So you can do that in the evening, whatever, but sleeping is at nighttime, overnight, and do that in bed, but don't do all these other activities while laying in bed. That doesn't work well. And so those are components. Again, the bright light phenomena has kind of become a big deal. What kind of night, if you still have an alarm clock of some sort, is that too bright, whatever. I still use one. I turn mine away, actually, from my face, so it doesn't really hit me at all. It's actually, and if I want to see what time it is, I have to actually physically move it, but which is a pain. But I tip it away from me so that light's not hitting you. So light's important, and the type of light you're getting exposed to can impact your sleep. Pets, whatever else is interrupting your sleep is something to think about and figure out how to do that. One of our dogs gets up like 4 times a night just to check to see if we're still in bed. Yeah, we're still in bed. You stay in bed. Don't wake up, because it wakes me up every time. So we need to look at all those components for good sleep hygiene, and sometimes that's all you're doing is telling them to do these things instead of what you've been doing and identifying those problems. Cognitive behavioral therapy, again, is going to look at specific things, that stimulus component, the restrictions on sleep or napping, relaxation techniques instead of napping or doing other things during the day, opposite types of activities, biofeedback mechanisms, whatever, to help reduce stresses and some of those other components that might impact on sleep and sleep regulation on a day-to-day basis. So those are important things to happen. People laugh every time, but the bed is for 2 things: sleep and intimate activities. That's it. Otherwise, you should not be laying in your bed or sleeping or doing anything else in bed. So what are we looking for from a pharmacologic standpoint in terms of an ideal hypnotic agent? We want it to work fast. So we want, if you're having trouble getting to sleep, we want it to work fast. It gets you to sleep quickly, less than 30 minutes. So rapid onset. Sleep through the night. You don't want to wake up multiple times because you're impacting that staging. So every time you wake up, come up to full arousal or awake, then you're impacting that cycle that's going on. So we want to sleep through the entire night. We want no resultant daytime impairment. So we want our medication to work during the night when it's supposed to, get us to sleep, keep us asleep, but not cause sedation during the day or fatigue feelings during the day or whatever, grogginess during the day. It cannot impact that and overflow into the daytime. And then no abuse potential. So no potential for misusing it or overusing it or whatever. So those are our ideal components of our hypnotic agent in the treatment of sleep disorders or problems. And we'll get to whether we have any of those or not eventually here, but and we have some products that come close to that. So here I contrasted DSM-4, DSM-5 a little bit because there are a little bit of differences between the two. In DSM-4, we talked on the left about historically about primary sleep disorders, and then they had dysomnias and parasomnias as subcategories to that. And we had the relationship with other mental disorders and those related to medical conditions and then substance-induced. In DSM-5, it's become more descriptive about things, so insomnia disorder, meaning just having difficulty getting to sleep, hypersomnolence disorder, oversleeping, sleeping way longer than they should, narcolepsy, which we'll talk about narcolepsy as a sleep disorder, breathing-related sleep disorders, so we kind of went away from calling them specific things, and I'll get to that as well, but breathing as a global group related disorders, circadian rhythm sleep-wake disorders, so we call that a jet lag or shift work issues, so circadian rhythm sleep disorders, non-REM sleep arousal disorders, nightmare disorder, which went back to parasomnias in the other side on DSM-4 in the past, REM sleep behavior disorder, restless leg syndrome, which we'll talk more about, and then substance or medication induced. So they kind of moved things around a little bit and pulled out some more specific terms in some ways or general terms in other ways to describe. So there were some major, fairly significant, at least terminology differences sorry, in DSM-5 versus DSM-4. So I think we're out of time. Any questions on eating or sleep or anxiety disorders today? All right, good luck on law.